Chains, it's a deep topic. Anyone looking to learn more about Voida just needs to know their anatomy, right? We can't sit here all day and teach anatomy. But considering these chains and your level of understanding, one thing you've taught me that's been crazy valuable is quickly screening QL and serratus posterior inferior on the same side to try to gather information as to whether we target the hip or the thoracic spine. Give us some insight as to how you landed on that screen, what it means to you as far as the chain is concerned, and how you've extrapolated that to other rotational joints like the shoulder.
So understanding the chains and how chains function, I started to fortunately have a busy practice, and patients come in with a variety of lumbar, pelvic related issues, and if I have a late day on a Friday and I got a patient that's come in and they're struggling, I want to be able to rapidly determine, what am I dealing with? Am I dealing with a disc? Am I dealing with the spine? Am I dealing with a facet? Am I dealing with the pelvis? And understanding how chains function, I started just doing a very light tonal palpation of the QL and serratus posterior inferior on each side. And what I have found is that if I have an asymmetry in the tone, right to left, of serratus posterior inferior and the QL, I'm going to look at their pelvis, because the relationship of those two muscles to the oblique abdominal chains and how they're influenced by the pelvis more than by the spine themselves, I'm going to address the pelvis. If I have a symmetry in tone between the QL and the serratus posterior inferior, being that each of them has a balance in tone, then I'm addressing a spine-related issue. If I were to move into the shoulder, I do a very similar thing. If I have the patient prone on the table, I will check lat. I will check on the side, I will check serratus anterior, and then supine, I will check subscap and subclavius. And if I find that there is an asymmetry in tone in those muscle groupings, then I will go at their shoulder, as opposed to going at their thoracic spine, or as opposed to going at their cervical spine as a priority. So I'm looking to, as Voita would say, the key joints are your hips and your shoulders. So that naturally, that kind of led me to start to think about hip function and how the hip plays a role in spine care, and the role of the hip, and this screen has turned for me to be very, very valuable. What's even of greater value is the experience I have if I use it as my treatment guidance that first day. So if I have a patient who comes in with difficulty in gait, difficulty getting up out of a chair, difficulty in flexion, but I have that right QL and that right serratus posterior inferior way more hypertonic than the left, I'll go a little further. I'll check a couple of the muscle groups. I may check the femorotabular joints, long axis traction mobility. But if I go ahead and I treat them, and next time I see them, if their symptom, what will commonly happen is they'll feel good after that treatment. If the next day they continue to feel good, then it's a hip-based issue. If they feel good that day, but the next day they wake up and they're back to where they were, usually they come in, next time I see them, that oblique abdominal chain has cleared up, and now I can address the spine. And for me, that's a very, very important feature, because if I don't clear up their pelvis, I'm not going to clear up their spine.
The term pelvis, let's just make sure that we're all on the same page with that. So we are not talking about the femoral acetabular joint in this case, or are we? Do you include that in your definition of pelvis?
We're talking everything that is the hemipelvis. So we're going to talk the SI, we're talking psoas, we're talking femoroacetabular joint. We might even be talking the foot and the knee.